Have you ever wondered if your anxiety was caused by perimenopause? Well, I'm here to tell you it can. I want to spend time in this podcast discussing how and why this happens and what treatment options help. Hi, I'm Dr. Jumana Aldeek. I'm a board-certified family physician who specializes in perimenopause, menopause, and metabolic health. Before I went to medical school, I was an NASM-certified personal trainer and health coach, and I helped launch a nationwide personal fitness company called Send Me a Trainer. That experience taught me that lasting health is about much more than prescriptions. It's about understanding how movement, nutrition, hormones, and lifestyle all work together. Today, I bring that same philosophy into my medical practice by combining evidence-based medicine with practical strategies that help patients feel their best. If you enjoy this content, please click subscribe so you can be up to date on the most hot topics in midlife. Remember, I'm a doctor, but I'm not your doctor, so please discuss with your physician before seeking care. And finally, if you like what you see and you want to become a patient, see the link below at medmethoddirect.com to join my telemedicine practice. So let me tell you about a frequent conversation that I have in my office every week. I get comments from women like, I have never had anxiety before, but now I do. I don't know what's happening. I'm waking up at 3 a.m. in panic, and I suddenly have a fear of driving on the highway, and I never had this before. And 9 out of 10 of these women, when I look at their age, they're in their upper 30s, 40s, or 50s. I'm here to tell you that anxiety isn't always psychological. Many women develop anxiety for the first time during perimenopause. It isn't because they're weak. It isn't because they're stressed. Their brain chemistry is literally changing. Let's talk about the menopause emotional roller coaster. During age 35 to 40, your hormones are stable. During ages 40 to 52, most women start to enter perimenopause. This is when women get the highest anxiety risk. Then it's your final menstrual period or menopause, because remember, that's just a day, remember, in the life cycle. During the first 1 to 3 years after menopause, hormones finally begin to stabilize and symptoms improve. And finally, when you're 55 and plus, the majority of women start to have improvement, but there's still a small cohort who have anxiety that lingers. Anxiety risk is not evenly spread across a woman's life. It clusters tightly around that transition zone itself. So how common is it? Up to 40 to 60% of women report anxiety symptoms during menopause transition. That's the vast majority of women. Women with previous anxiety have a higher risk, and many women develop anxiety for the first time in their life. Let's talk about why estrogen matters. Estrogen isn't just a reproductive hormone. It affects almost every neurotransmitter, including serotonin, dopamine, GABA, acetylcholine, endorphins, and more. When estrogen fluctuates, like it does in perimenopause, everything fluctuates. We're going to talk about some of these neurotransmitters in detail on the next slides. Let's talk about serotonin first. This is a natural chemical messenger in your brain that helps you feel calm, happy, and emotionally balanced. Think of it as your brain's feel-good messenger. When serotonin levels are healthy, it's easier to feel positive, handle stress, stay emotionally steady. When serotonin is low, you may feel more anxious, sad, or irritable. Estrogen helps maintain healthy serotonin levels by increasing its production, slowing its breakdown, and improving receptor sensitivity. As estrogen declines during perimenopause and menopause, serotonin activity decreases, which can contribute to anxiety, depression, irritability, and mood changes. Estrogen enhances dopamine signaling, and this affects motivation, pleasure, confidence, concentration, reward. Women end up feeling like not themselves when they have low dopamine. Progesterone has calming effects on the brain, but not because of progesterone itself. When progesterone enters the brain, it's converted into a powerful neurosteroid called allopregnanolone. Allopregnanolone binds to GABA-A receptors, the brain's primary inhibitory or calming receptors. Activating these receptors reduces neuronal excitability, which is why many women feel more relaxed, sleep better, and experience less anxiety when progesterone levels are adequate. During perimenopause, progesterone levels often decline years before before estrogen does. As a result, allopregnanolone levels also fall, reducing GABA activity and contributing to anxiety, insomnia, irritability, and that feeling of being constantly on edge. This is one reason micronized progesterone can improve sleep and reduce anxiety in appropriate patients. Think of GABA as the brain's brake pedal. Progesterone helps press that brake. When progesterone falls, the brain loses some of its natural calming power. Why is this important? Progesterone often drops first. That means less progesterone converting to allopregnanolone and causing less GABA activity. Remember, the receptor that controls calming, causing more anxiety and more insomnia. Hello, 3 a.m. wake up. So why does anxiety peak during perimenopause? It's not because estrogen is low, it's because estrogen is unpredictable. One week it's high, the next week it's low, the brain struggles to adapt. As you can see, there are huge peaks and crashes. This irregularity is what causes the symptoms of anxiety, not simply the estrogen deficiency. Estrogen helps regulate the stress response. Estrogen acts like a buffer for the brain. When estrogen declines, you get a greater cortisol response, and the stress becomes more reactive, and so even small stress feels overwhelming. Let's talk about the vicious sleep cycle. We have poor sleep with the nightly 3 a.m. awakenings, which causes higher cortisol that drives the anxiety. Then there's more hot flashes, which cause even less sleep and higher cortisol and more anxiety, and it just goes around and around. Let's discuss heart palpitations. Actually, this is very common in women during perimenopause. When I see them in my primary care clinic, I usually work them up with labs, EKG, Holter monitor, stress test, echo to rule things out like AFib, SVT, hyperthyroidism, etc. And then 90% of the time, there's nothing visibly wrong with them on labs or imaging. But there is. Estrogen affects the autonomic nervous system, blood vessels, adrenaline. It can trigger the flight or fight system in the body. The massive fluctuations can trigger palpitations, which ultimately trigger anxiety. These are the brain regions in the fear response. Estrogen plays a key role in keeping your brain balanced. It helps the logic center or the prefrontal cortex communicate with the fear center or the amygdala and the memory center, also known as the hippocampus, so you can think clearly and feel safe. Without estrogen, fear wins. Women with a history of any of the following risk factors: premenstrual syndrome, premenstrual dysmorphic disorder, postpartum depression, anxiety, PTSD, and anxiety are a lot higher likelihood to experience worsening anxiety in perimenopause. There are natural treatment options that can be used to treat anxiety, including working on sleep hygiene, exercising, resistance training. You can also focus on your diet by eating more protein-packed meals, reducing your caffeine and alcohol intake. There are also natural forms of stress reduction like mindful breathing, exercises, and yoga. There are also non-evidence-based supplements that can be used, but they are anecdotally in practice, they've helped, like magnesium glycinate, which helps with sleep, L-theanine, ashwagandha, omega-3, vitamin D if you're deficient. The evidence varies with each one. I recommend talking to your clinician. Cognitive behavioral therapy, or CBT, is the only evidence-based non-drug treatment that can be used for perimenopause anxiety and is especially effective for health anxiety, panic attacks, and insomnia. You might be wondering, what exactly is CBT? Cognitive behavioral therapy is a structured, evidence-based form of psychotherapy that helps people identify and change unhelpful thoughts, emotions, and behaviors that contribute to anxiety, depression, and other mental health conditions. The core principle is thoughts lead to feelings, which lead to behaviors. If we can change how we interpret a situation, we can often change how we feel and respond. There are several medications that can help with anxiety. This is by no means an exhaustive list, but just a few examples. Selective serotonin reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors, buspirone, hydroxyzine, benzodiazepines, to name a few. Each has its pros and cons, and some require you taking them for 3 weeks before you can see results, and others are only meant for short-term use. Now, does hormone therapy help? This is where many women get confused. Evidence suggests that estrogen therapy can improve mood and anxiety in some women, particularly when symptoms are closely tied to the menopause transition and accompanied by vasomotor symptoms like hot flashes and night sweats. It is not considered a primary treatment for generalized anxiety disorder in women without menopausal symptoms. It can help stabilize estrogen fluctuations, especially in early perimenopause, improve sleep, reduce hot flashes, improve serotonin and dopamine signaling, and indirectly reduce anxiety by improving overall quality of life. We've talked about estrogen, but what about progesterone? Micronized progesterone is converted in the brain into allopregnanolone, a neurosteroid that enhances GABA, the brain's primary calming neurotransmitter. This can promote relaxation, improve sleep quality, reduce nighttime anxiety, and quiet racing thoughts. Oral micronized progesterone has the strongest evidence for increasing allopregnanolone levels, although individual responses vary. Current guidelines do not approve of hormone therapy as a sole treatment for anxiety, but HRT can improve anxiety when it's associated with menopause, especially if it's vasomotor symptoms that are present. The greatest evidence is for women within 10 years of menopause or younger than 60, provided there are no contraindications. However, that does not mean women over 60, after discussing risks versus benefits, cannot be on it. Let's delve into some of these specific studies. There is one by Loza and Piacco et al., which was completed in 2022. This randomized study evaluated transdermal estradiol in perimenopausal women. Estradiol treatment reduced anxiety and loss of pleasure, with the greatest benefit seen in women whose mood appeared especially sensitive to estradiol fluctuations. There was a study by Gleason et al. In 2015. Postmenopausal women were randomized to oral conjugated estrogen, and transdermal estradiol or placebo. Oral conjugated estrogen produced small improvements in anxiety and depressive symptoms compared with placebo, while transdermal estradiol did not show the same consistent mood benefit. There was a study completed by Can et al. In 2015. This was a randomized trial comparing low-dose oral estradiol, venlafaxine, which is an SNRI, and placebo in women with bothersome vasomotor symptoms. Estradiol improved menopause-related quality of life and some emotional symptoms, although this was not primarily an anxiety disorder trial. It supports the idea that treating hot flashes and sleep disruption may indirectly reduce anxiety-related distress. So a lot of good evidence here. A necessary caveat: we've talked about when anxiety can be caused by your hormones, but any anxiety that is accompanied by severe depression, mania, psychosis, suicidal thoughts, panic disorders predating menopause, hyperthyroidism, substance abuse, etc., should be evaluated. Perimenopause doesn't create weakness. It changes the chemistry of the brain. In other words, your anxiety may not be all in your head. Sometimes it's in your hormones. The good news is that there are effective treatments like lifestyle changes, therapy, medications, and hormone therapy that can help. Thank you so much for listening today. I hope today's conversation has helped you better understand what's happening in your body and reminded you that there are evidence-based solutions available. If you're looking for personalized care, I'm the co-founder of MedMethod Direct, a telemedicine practice focused on perimenopause, menopause, obesity medicine, metabolic health, and preventative care. We provide evidence-based, individualized treatment plans for patients in multiple states, all from the comfort of your home. You can learn more at medmethoddirect.com, and you can also find additional educational content, articles, and resources on my website, drjumanaaldeek.com. I love sharing the latest research in a way that's practical and easy to understand. Thanks again for listening, and I look forward to connecting with you.